Excited to have our next installment of our visiting professors. We have a foot and ankle visiting professor today, and I'm going to have Joe Park, our division head, introduce our esteemed speaker. This is recorded, and many of our alumni join through the virtual link as well. So there's a big audience here today for this lecture. So looking forward to both of them. So Joe.
All right, so it's really an honor to introduce Anish Kadakia today. Sorry, Anish. I want to steal your thunder. I'm going to skip this, sorry. All right, so
I'll see you later.
Perfect. So Anish did all of his training at Northwestern, including undergrad, med school, residency, and then he did his fellowship with Mark Myerson, who really was one of the giants of our field. He then started on faculty at Michigan for about 5 years until he went to Northwestern, where he's now full professor, division head of foot and ankle there. Anish is probably one of the busiest people I know. Every time I talk to him, he's in a different country or different area, but he's given over 200 international lectures and almost 300 national lectures. So I just thought about how busy I feel like I am. That blows my mind. He's written over 65 peer-reviewed publications, and he's written 56 book chapters. He's done lots of review courses, including the AOS, so he's well known throughout everybody. But personally, Anish and I, we started the AOFAS Ortho podcast together. Probably one of the things I'm most proud of, and he's been such a great person to do that with. We've done other things together as well. He's a huge car enthusiast. He can talk a little bit about that. I'm not going to steal his thunder in case you are going to talk about that. And Anish has 4 kids with his wife of 18 years, Sakina. So I'm going to let him get to his talk, but thank you so much for joining us. We had a great time last night, and thanks a lot.
Well, thank you all very much for allowing me to come here. It's an honor and a privilege to be here. You got a great core of faculty. I don't know if the residents realize how lucky you all are. You got a great chairman, and you got a great group of faculty, and it makes a huge difference when you all get along. This is now my 3rd job, hopefully my last, unless Peabody fires me. And I'll tell you, the faculty make a big difference. So I was asked to give 2 different talks, one about academics, which is my LisFranc talk, and then one about work-life balance, which I did on my wife's birthday on Sunday. So I'm not an expert at it, but I'm learning every day. Joe only said, only if you have the talk ready, please give the talk. I said, yeah, I got a talk ready. Don't worry about it. So when we talk about LisFranc, it's a very common injury that we have. It goes from the blowout of your foot to a subtle injury. And it's actually one of the most litigious things that we treat as orthopedic surgeons, commonly missed in the emergency room. We miss it sometimes, and it can cause a lot of disability. And so this is not a medical legal talk, but it's one of those things I think is relevant, not just, A, how do you fix it, but B, we got to always keep in mind the diagnosis. So we look at this as when I was a resident, this was basically one of the big studies that was out there, and it was the Hansen studies. They looked at their patients for fusion versus RIF. And what they looked at for RIF was that a quarter developed arthritis after a LisFranc injury, 12% required a fusion, so about 1 out of 8. And this is the funny thing, back in the day, we actually had to tell ourselves you had to get an anatomic reduction, which now would be kind of basic thought process. But as orthopedics has developed, no one really understood that you had to get a perfect reduction to have a good outcome. And so that's now dogma, but you got to remember 25, 30 years ago, that wasn't the case. And this was known a long time ago. Purely ligamentous injuries did worse. And as we know in the ankle joint and other joints, which I don't pay attention to anymore, ligament injuries are very hard to reconstruct. The ligaments just don't heal as solidly as we would like to. This is the other article by Lee and Kotsia. These are the seminal articles for any resident and fellow. Eddie, you should know these like this, the top here. The back of your hand, as people say, but I don't know what the back of my hand looks like. So 20 fusions, 20 RF, a very small number, 3.5 years follow-up. Short summary, the AOFA score showed higher outcomes in fusions. And the reason, the thought process was that when you have a stable midfoot, they no longer have pain. And so this suddenly changed. Everybody wanted to fuse every LisFranc injury that walked in the door. And orthopedic surgeons were very gut-driven. We see an article, we're going to just suddenly go now 90 degrees, different direction. And that is probably the worst thing you can do because you end up treating people incorrectly. So the simple radiographic findings, the question is, why would you fuse this? This is a subtle injury. Does this need a fusion? This is a 22-year-old patient walks in, trip and fall, has this injury. Do they suddenly need a midfoot fusion? That's the question. The answer is, I don't know. I'll give you my thoughts on it. But prior to that article by Lee and Coetzee, this would have been an RIF hands down. And I bet you in most of the foot and ankle surgeons' hands, this is an RIF. Open it, put screws across, call it a day. But now would you fuse that? And what you always want to make sure there's no such thing as partially injured. The LisFranc ligament's intact or it's torn. A subtle injury is a subtle injury. So that on the right side is by definition a LisFranc injury. You always want to get that weight-bearing x-ray, and don't convince yourself something is normal. Convince yourself something is wrong. It should be blatantly obvious that it's normal, and that person on the right needs surgery. When that's left neglected, they will do poorly. This is a flex sign. This one is not as bad. So this is a tiny fleck. It's an avulsion of the LisFranc ligament. And the question is, does this need a fusion now? This is a ligamentous basically injury, but would you go ahead and do a big operation and fuse this, or could you just put a screw across? Most important thing is there's no non-operative role for this injury. Then you have the obvious ones, these complete dislocations. And this one is very reasonable to fuse. This person's foot looks like gobbledygook, right? Joints are all over the place. The ligaments are torn top, middle, and bottom. Trying to put this together with a bunch of screws is probably not going to work because there's nothing that's really left to heal properly. Then we can talk about advanced imaging. Do you have a weight-bearing CT here at all, Joe? So as weight-bearing CT and all this newfangled imaging comes in, the question is, do you even need these CTs, or just did you need an X-ray? Well, this is a high-energy injury. It's not useful for the diagnosis. Everybody can tell, hopefully, there's an injury to the midfoot. However, the question is, what do you have to do? And therefore, CT is helpful for trying to decide what joints might need a fusion, what might need an RIF, if you feel that the midfoot has relevant motion. But now you have this kind of injury, very subtle. So what would you do? Unilateral weight bearing, bilateral weight bearing, stress radiography, CT, or MRI. All of those are relevant options. Stress radiography has been proven. There's a gentleman, John Camino, who I took over his job from Michigan. Dave, I don't know if you remember John, but he published an article in JBJS that showed a stress radiography is better than double limb weight bearing for LisFranc injuries. The problem is, thank you, Joe. The problem is there's a lot of difficulty in getting those. You have to anesthetize the midfoot. You've got to get into the fluoro suite. It takes time and energy. And if you've ever done to try to do a midfoot stress radiography, it's crazy. It's hard to do. You've got to get the right angle. And so most of us practically just refuse to do it. People said go to the operating room and then do it in the OR. If it's stable, don't operate. But that's not really medical legally appropriate, and probably ethically not appropriate. Don't want you to get anesthesia, spend all that money, and be like, I don't think I'm going to do anything to you. You should be able to figure this out beforehand. I do unilateral weight-bearing x-rays, and the MRI is also very useful, but weight-bearing CT is really where I think a lot of the relevance comes in. There's no consensus for non-weight-bearing CT. In general, for non-weight-bearing CT, I would suggest that's only to tell you what to do if you already know it's a LisFranc injury. But if you are unsure, a weight-bearing CT is probably the best way. You can see here, there's subtle on the radiograph. You can see on the weight-bearing CT, and it'll really let you know if there's a injury or not. This is a lot of data, and I'm not a big data-driven guy. I'm not going to waste your time. But in short summary, when you don't know, the weight-bearing CT will unmask those subtle injuries so you don't miss anything. And one thing that's coming out with weight-bearing CT is that it's a volumetric ability to diagnose. So if you look at the volumetric space between the second and the medial cuneiform, and then you look at the left and right injured side, that's how you diagnose versus just straight linear aspect. And that's for the syndesmosis as well. Pitted Physical, I don't know. I mean, everybody knows him in our little world, but he does a lot of these weight-bearing CTs for syndesmosis. And that's what they show too, that volumetric analysis is the best way to do it. So again, non-weight-bearing CTs to tell you, hey, look, I think something's broken, but isn't in the joint. Do I need to do a fusion? And then it has no real role for is something broken or not, but it lets you see other things, navicular fractures, subtle fractures you may miss with a standard x-ray. So if somebody has a LisFranc injury in our practice, I diagnose it. They always get a CT scan because I want to unmask the other injuries that I might miss. And it's not all the time, but if you miss it, you actually, it's a huge problem. Then weight-bearing CT I talked about, it's the volumetric aspect. And a lot of people are pushing this. Cesar De Neto is one of our huge proponents of weight-bearing CT, has a lot of data on it if you're interested. But in short summary, weight-bearing CT does help, but it's not the perfection that everybody hoped it was. You can still miss things, but it is very useful. It's all about volumetric measurement, which is a real pain to do. You have to have a software to look at this. You have to have patience. But if you have the ability to do this, you can pick up a lot of subtle injuries. There's a cadaveric study showing that how much diastasis do you actually get when you cut the ligament? And this has been done for the syndesmosis as well. It's not the same group. This is Charlie's group. They looked at 4 conditions: no damage, dorsal LisFranc ligament, interosseous, and plantar. Then after that, they cut everything else. The interesting thing is if you look at the group 4, which is where you've cut all of the ligament, you get, sorry, the amount of diastasis you have is not that much. It's 1.5 millimeters more if you look at this. So subtle LisFranc injuries are just that. They're very subtle. So when you look at C1, M2 distance, it's only 1.5 millimeters of difference on a weight-bearing CT with a complete LisFranc injury. So if you have an MRI, LisFranc is totally torn, only 1.5 millimeters of diastasis. The problem is you as a surgeon, as a human being, cannot diagnose 2 millimeters of difference on a plain x-ray. You can't tell the difference. There's a study that looked at that for LisFranc injuries, that you as a human being, if I gave you a 2 millimeter difference versus 1 millimeter difference versus 0 millimeters anatomically, the x-ray, you can't tell the difference. So you're going to miss a lot of these injuries. So somebody comes in with plantar ecchymosis, midfoot pain, x-rays look normal, but they're having a hard time. Get an MRI or get a weight-bearing CT, that person probably has a subtle LisFranc injury that you're just not picking up on a plain x-ray. And that's the relevance of these anatomic articles. It shows you that we can't pick up that much. And the syndesmosis is the same thing. And the other question is, what do you do for the first TMT? What's the ideal procedure? And CT may be more relevant here. You can see on the left side, you've got abduction, some instability. Are you going to fuse the first TMT? Are you going to do an internal brace? And the weight-bearing CT here, you can see there's gapping on the plantar aspect, consistent with instability. It probably needs some sort of stabilization, which I'll get into what the options are. But you can do an RIF, you can do a massive midfoot fusion, or you can do some crazy stuff like I do with the internal brace to stabilize these people. And that's what I did. So I did a second TMT fusion because I do believe you have to fuse that. And then the first, once you lock the middle column, you no longer have the abduction, but you have the sagittal instability. And so I did an internal brace plantar medial for the first TMT because now you're trying to isolate the instability patterns without fusing the medial column, which is mobile. So fix or fuse, that's the primary question. And so what I always ask myself is the first TMT motion relevant? And in general, I think as physicians, we've always said, well, these joints are not relevant. We can do whatever we want. The appendix, the X, the Y, the syndesmosis. And in general, we've all been proven wrong. God put them there for a reason. Don't destroy them. Now that's somewhat relevant here. The first TMT is probably more relevant than you think. It has about 1 centimeter of motion in the sagittal plane. In most patients, some are stiff if they're cavus. And if you feel it's relevant, you should probably fix it. If you feel it's not relevant, then you don't have to think. You can fuse every first TMT that walks in your door. If you train in Seattle or in Grand Rapids, you fuse them all. And that's your philosophy, and that's okay. The middle column, the question is that motion relevant? Well, that's probably not relevant, and that's my thought. We used to try to save this motion, and some people still do. When you look at the motion in the middle column, it's like 2 to 3 millimeters. I think the middle column is primarily for force transfer from the forefoot to the hindfoot, and it really just needs stability. That's what causes them pain. When you fuse the midfoot, there's not a lot of functional loss of motion. If you do an RIF and there's some subtle instability, they have inability to transfer force, and they have pain. So you can either closet fuse, like Kadakia says, where you just put plates and screws across and leave them in forever, or do a formal fusion. But I don't longer just quote unquote fix them and take the hardware out. When you look at the data, this is Bohan and Anderson's data. And if you look at their data, there was no difference in fusion or RIF, but the RIF group had a lot of secondary surgeries, that being hardware removal, which is expensive for the patient, better for the surgeon. But our job is not to be selfish and better for us, it's better for the surgeon. They concluded that no matter what you do, it's kind of either technique's acceptable, but with fusion being the same outcome without secondary surgeries, it's probably better. Then the question is, how do you fix it? Well, I was trained to put screws across the joint, and that's what you do. Just like the syndesmosis back in the day, you put screws across. But now for the residents and the fellows, that probably seems insane. You don't put screws across joints, and the question is, are you causing damage? You look at the 4 millimeter screws, a 12.4 millimeter circumference or diameter, not diameter, surface area, and then the mean percent of joint disruption is about 8%. So if you put a screw across the joint, you're destroying 8%. That doesn't account for the heat necrosis that occurs, and that doesn't account for the fact that no one gets them right on the first time. How many passes have you done to get these correct? I'll honestly tell you, it's usually not one. So you have multiple points of damage to the joint. So now you've created articular damage and a ligamentous injury where there was no articular damage. You did it. And no wonder these people got arthritis. And it's just an anatomy. We would usually put 2 screws across the first TMT, a single screw across the second TMT. and you're damaging these very small joints, causing arthritis and pain. This is where I learned that I think I was the problem. This is a 40-year-old soccer coach at the University of Michigan, subtle LisFranc injury, but it's obvious there on the left. The first TMT I thought was unstable. I got him aligned adequately at the second, not perfect, but that actually wasn't even the problem. Look at his first TMT. That first TMT did not deserve any surgery, nor did it deserve to get degenerated. The only reason that occurred is because of my fixation. I put screws across his joint. He did not have massive damage. And this is like a month after that, I saw Bob Anderson. I talked to him about plates. Like, I think I'm doing something wrong. And I stopped after this is the last case I put screws across the first TMT. I think the surgery was a disease, not a cure for this patient. And that's when I realized I think we are the problem for screws across the joint. Can you use plates? I think a lot of you guys all use plates now, right? I think using plates more often than not. But this was not something that was conventionally assumed was okay. And so it's proven plates are strong. Plates are better because they're pre-contoured. It helps in the reduction. They're stiff. You won't get arthritis as there's motion, and failure will not lead to intra-articular hardware. There's a lot of benefits to it. There's always downsides. You got to cut these people open, so there's more risk of wound complications. To get the hardware out, you can't just make a small nick. So there's always a downside. But I think the benefits outweigh the risk because you're not doing any transarticular fixation. So let's get to some cases. So when we look at the 3-column injury, this is a bad injury. This person needs a surgery. Obviously, you can see the 1 through 5, it's all dislocated. So I did a transarticular plating, 1, 2, 3, and 4. I felt I got a good reduction. One thing I learned over time was that you do have to put a LisFranc screw across. We finally had a publication that we presented at AOFAS that shows that when you fuse the middle and medial column, biomechanically, there's actually increased strain to the LisFranc ligament. It's not the same. And so what happens is you'll get that subtle diastasis over time between C1 and M2. And that's the reason when we do Lapidus, in general, you're trying to put, now a lot of us will put transarticular fixation, not transarticular, fixation from C1 to C2 or from the first metatarsal into the middle cuneiform, because one of the reasons why you get recurrence after Lapidus is failure of the LisFranc ligament, which was totally normal. And the reason that occurs is there's strain there. But I didn't do that in this case, and he did fine. We took everything out, but he's got some arthritis in the foot. When you look at that, ideally, this person should have had at least a fusion of the second and third TMT. They get arthritis no matter what you do. But the broken hardware did not lead to transarticular screws. So it's kind of a nice, easy way to do it. When I first came to Northwestern, I had a big britches, big shoulders. I had to prove myself that I came back from Michigan to my old alma mater, and I am the man. That was my thought. So I walked in, first week, this gentleman came in, police officer thrown from a car. He was trying to save somebody's life. Bad injury, 1 through 5. He's a 40-year-old gentleman, want to return to work. I said, I can fix it. So I did a 1, 2, 3, 4 ORIF, navicular fracture, and I thought, man, I did a really good job. Got him back exactly where he'll be. He's going to go back to work. This is my 3-incision approach. I do a medial incision, a lateral incision, and I do a way lateral incision. I'll show you. I no longer go in the first web space because I had a lot of nerve injuries because the DPN and first dorsal interosseous artery is there. And if you're doing that approach and you see the entire first TMT and second TMT really nicely, well, the artery is out the door. And I used to get a lot of hematomas and pain. So I stopped doing that. And that's what the final incision looks like, even on a bad injury. The benefit is you're looking right at the joint. It's the easiest exposure in the world. You look right at it, anterior tib is proximal, just proximal, and you can get it out of the way. You get these nice plates on there, and you can look directly at the second TMT. So there's your disruption. Plate goes on and actually pushes it into place. So it aids in reduction, and I've never seen the DPN and the first dorsal interosseous artery in the last 10 years. It's very nice and easy to do. If you have to go lateral, you can. But this is the problem. Arrogance is the problem. So I was like, I'm great, but I'm not. The gentleman took out all his hardware. Everything fell apart. He had continued pain, discomfort. I ended up doing a midfoot fusion with 4th, 5th TMT arthritis. As you can imagine, he never went back to work. He had 3 surgeries to get to that last x-ray. That should have been my first x-ray. You cannot fix what's that damaged. You have to have some sense that you're not better than nature itself. And so try to do the best thing. Don't get too overconfident. These high-edge injuries, they need fusions. There's no question. This is a simple LisFranc injury. You can see here, simple LisFrancs will do okay. This ORIF took out the hardware, patient did fine. So subtle injuries can be fixed. The lesson is that high energies need a fusion, low energies you can fix. It's up to you. This is the subtle recurrence that I'm talking about. This patient, I took out the hardware. These are all old x-rays because this is the lessons that I've learned. And you can see it kind of fell apart. So do you need a LisFranc screw? Was the failure here that I wait 5-6 months to take out my hardware when I used to take it out? And so it recurred. So do you always need a LisFranc screw? And my answer to you is yes. And I actually never take out the hardware anymore to prevent this complication, except on the first TMT. And I'll get into that. Now my philosophy is, well, if I'm going to leave the hardware in, I think in general for the second TMT, just fuse it. It's easy to do, it's reliable, it's stable, there's no functional loss. And that's really what I do for all my LisFranc injuries now. But I think the first TMT motion is actually pretty relevant, so I try not to. If you have a smoker, a diabetic, a vasculopath, the question is, what are you going to do? Are you going to make a big incision? You can, and I have a lady who I just saw on Tuesday before I got on the plane. She had this type of injury. I did a percutaneous fixation, did not do well. She's diabetic, brittle. I had to open her up. She has a massive wound in the medial column now I have to wash out tomorrow because we don't want to get these complications. So if you're going to do it percutaneous, you just draw out the anatomy. I'm not going to make you watch the whole video. But if you draw out the superficial anatomy, foot and ankle is a very superficial anatomy field. You can actually identify everything. You can make your incisions and kind of direct the length that's your LisFranc screw, and you can actually percutaneously fix these patients in a high-risk situation. This is not for your 20-year-old athlete. And this is what it looks like. So you get your clamps, you reduce, you put your screws across solid or cannulated, it's your choice, and you can get actually reasonable fixation across the joint. There's a different one. These are retrograde screws. These are not perfect, but this is the best way to do it with a high-risk patient because you don't want their foot to collapse. And you don't want to make a big incision. So you keep that in mind that you can always do percutaneous fixation. And then if it falls apart, you can go back and do a midfoot fusion. But the benefit is that you've gotten away from that period of injury. So that second injury syndrome that occurs when we operate a week after all the soft tissue disruption, you let that all calm down. So you can deal with this on a more elective basis, but you can provide the midfoot stability so you don't get a massive deformity. It's like we have trauma partners here. I know it's trauma surgery. You don't always have to do the definitive surgery on day 0. You shouldn't leave them alone. And no one wants a big midfoot external fixator on the foot. That's not appropriate surgery either, even though Dave might put that on someone for fun. This is the NC variant. These are missed a lot. So when you look at your x-rays, everybody looks at the second TMT for LisFranc injury, but never forget that is intercuneiform diastasis, and the joint to look at is second TMT, but always look at the NC joint. And it's very obvious here there's a disruption. These are frequently missed. They have articular damage on the navicular. You have to open these up, distract them, put screws across. This is not great fixation, it's an older case, but you leave these screws in forever. Never take out these screws because that intercuneiform joint never heals. I now roughen up, bone graft, and actually get intercuneiform fusion, but never take this hardware out because it will always fail. And then LisFranc injuries can't be classified. So you have all these beautiful classifications that I mentioned, none of them. And the reason is they have no relevance or role. Sometimes it's just bad. This kid got in a massive accident. I don't know what that is. And so you end up no idea what's happening. So you put an X-fix on. In some cases, you have to do that. Let the soft tissue calm down, understand what's happening, and then just put a bunch of metal in there and get him to fuse. He had no bone laterally. It was a gunshot. No bone laterally. Used a bunch of screws. I went to a course and I was like, you know what? I should be able to do a LisFranc with screws. Went to a Synthes course. I was like, that's it. The trauma folk are all doing these screws and they got skills. I just wanted to prove to myself, you don't need expensive metal. And I do a lot of mission work now. And the truth is we're all trained on these very expensive implants. And I'm a big proponent of big implants, expensive implants. I use a lot of fancy stuff, but you should always go back home. And most of the stuff we do can be done with a very cheap screw. And I just needed to prove to myself I could do it again. And it works really well. So you reconstruct their foot. There's no science. There's no classification for this. Just put the foot back together and make it look like a foot and make it stable. They're missed a lot too. So in this case, this gentleman's workers' comp had an injury to his foot and he told he had a foot sprain. If you look at the x-rays here, there's really nothing that bad. But what can you notice? That these were non-initial, non-weight bearing x-rays. He had a lot of pain in the midfoot. And then he came to see us, and I'm like, something's wrong. And we got a CT. You can see he had a medial cuneiform fracture and a subtle LisFranc injury to the second TMT, as you can see on that top right x-ray. There's a subtle injury here, but he now has a 2.5-month-old chronic medial cuneiform fracture. And so it's easy to miss. This x-ray is very subtle. If you look at this carefully here, you can see maybe there's a subtle malalignment here, but you never would have known because they never got a weight-bearing x-ray. So now I went from a minor injury that would have been simple to do to you had to fix the fractures. I did a plantar plate fixation and do a second TMT fusion. I just put a screw across, got the second TMT to heal plantar plate, and he went back to work. But now you have to really do a much different approach. I had to fix his cuneiform fracture, fuse the first TMT because it was damaged, and do an ortho the second. Where maybe all he needed was a second TMT plate and a little screw across the medial cuneiform. It would have been fine. So now the athletes. The question is, and an athlete, is their career over? And it's a tough question. You all deal with athletes here. I think Joe has way more athletes than I deal with. And our athletes are Northwestern athletes, which everybody mocks us, but they're real athletes too. They're just smart, that's all. And so the question is, can you get an athlete back to play, or do you tell them your career is totally over? This has been looked at in different ways. These are rugby players, but they looked at this classification. The Nunley classification for athletic LisFranc is probably the most useful. But they had 17 players. In short summary, 16 were able to return to play at 20 weeks and full competition 25.3 weeks. Nunley 2s are very subtle injuries. They're basically subtle damage to the second TMT without significant disruption of the third, fourth, and fifths, and there are no dislocations. So this very subtle second TMT abduction injury, those do okay without significant dorsal translation. So yes, you can fix them and get them back to play. Very confusing slide, not going to torture you. Basically what it shows is that in the NFL population, it does negatively affect your ability to get recruited and the length of play that you're going to have. And I'll summarize that here. When you look at the NFL career length, it is shorter if you leave them displaced. So LisFranc injuries do harm you for sure a little bit, but if you leave the second TMT displaced, their career length is shorter. It's a big deal. There is some surgeons say, oh, it doesn't matter if they have a subtle injury and you leave them a little bit wide, they can play, they can, but it does affect their career negatively just a little bit when you look at all the data. So if you're going to treat these athletes, you really need to stabilize and reduce that second TMT joint. They can go back and play, but if you leave them subtly off, they're going to do poorly. And the amount of displacement is negatively correlated with the time length of their career, which is a big deal. So we can learn it negatively affects your prospects to get recruited. If you are recruited to play, it does decrease your ability to play if you have diastasis. So that's the way to think about it. LisFranc injury, if you fix them, they have a lower chance of getting back to play than a non-injured athlete. But if they get to play, they better be perfectly reduced, if that makes sense to everyone. Then hopefully their career is going to be okay. And this is different ways that article showed you can fix them. And the internal brace is a concept that's out there for it. I'm not going to bother you about it. So what about when they're playing and then they get operated on? They don't do that great. Their return to play performance is worse. Offense is worse than defense because offense is a lot more cutting side to side, and that's what LisFranc injuries do. So if you have an athlete who's playing in the NFL or any professional type of sport, you have to let them know their return to play rate is about 80%. 1 out of 5 will lose their ability to go back to play, and the performance is going to be decreased because it's not a good injury to get, obviously, but it's not a game killer. So if you summarize, we can actually get most athletes back to play. It does not automatically end a career. Residual diastasis is a poor prognosis, and the fusion versus arthrodesis is probably a similar outcome for speed, but not cutting. There's a difference. This is a really nice article. It's a military article that looked at who's faster. Everybody assumed that if you fuse the midfoot, you're going to be slower. This is the return to duty test that military professionals have to do to get back after injury. These were all low energy cases, not high energy blowouts. And they were 30 seconds slower if you had an RIF. So based on this, at least you can understand that your speed to running is not negatively affected by doing a midfoot fusion. Second, third TMT, first TMT, whatever you want to do, you can fuse and they're not going to be slow. You're not going to disable somebody by doing a midfoot fusion. That's really important as we try to make these decisions. If you just want reliability, no second surgery, not multiple scars, fuse them and be done with it. But what about that first TMT? As I talked about before, there's motion there. And if you look at the anatomy, there's actually 8 millimeters of motion in different planes. It is a mobile joint. And I think the first TMT is relevant for your side-to-side cutting. If you're a cutting athlete and you're really doing a lot of side-to-side, you can't have that first TMT locked and expect the same function that you had before the injury. So I think you should try to stabilize that. That will stabilize without fusing. So going back to all of this stuff, the transarticular plating, LisFranc fixation you do need, and I'll show you what I did for the athletes now. So if I see a LisFranc injury, this is my summary here. Stable midfoot alignment is the best chance of return to play. Second and third TMT motion is not relevant, so I fuse those because I want that solid for force transfer. They can't have any instability. I think preserving first TMT motion is important for cutting sports. So if you're a cutting athlete, I'll show you what I do. I do a LisFranc for the first TMT and fuse the second and third. But if you're a heavy laborer, you're a lineman, you're just doing heavy weights, and you're not cutting, fuse the first TMT. They need stability. Low energies, small injury, maybe just a retrograde LisFranc screw, leave it alone, or a transarticular plate, don't fuse them, but don't take the hardware out on the midfoot because just be a closet fuser, it's okay. High energy, I fuse the first, second TMT, and I do the internal brace for the medial column, which I'll show you, because once you fuse the middle column, the first metatarsal cannot abduct anymore. So the 21-year-old collegiate athlete, we talked about this type of injury yesterday, not as bad, this is worse. First game, he's a senior athlete, starting, first time he got to start, and it was in San Francisco. First or second play of the game, this happened. So the kid was pretty bummed, and he wanted to go back that season. So that was his last season anyways. So what do? Well, we basically tell him his life is probably over for athletic activity. So 1 through 5 dislocation, they reduced it. So this is not a low energy injury, but I thought, what can I do to get this kid back to play? So I know he needed a midfoot fusion. So I fused second and third TMT, transarticular plates and screws. But then what about the first? So you can see here, before I did anything, it's unstable to abduction and sagittal strain. And there's no tourniquet true. The blood's everywhere, as we talked about. Truth is it's true. So then I fused the second and third TMT, and now it's really just stable in the sagittal plane, but I cannot abduct him anymore. And I think I try to show that here. I try to abduct him. He doesn't really go because there's nowhere for the first TMT to go. So at this time, I was like, well, maybe I can just do a internal brace to the first TMT, plantar medial, and now I've stabilized and eliminated that sagittal instability. But that's relying upon a solid midfoot fusion. And there he is at 9 months. He got a solid fusion. Joints look really good. I don't have to go back in and take out a plate. I think the transarticular plating causes a lot of stiffness. And the proof is in the pudding. And there he is. He's 9 months out, but he's not. He actually, this is it. This is 4 months out. And we actually got into a bowl game, which I know is surprising to everybody in the audience, but that's him playing. He actually played in that bowl game. So you can do amazing things if you just try. You get lucky sometimes. I've done this like 4 or 5 times. I think it does work. But concepts are evolving. So that's my long story short on LisFranc. That's what we say today. In 5 years, it's maybe a totally different lecture. Thank you very much. Any questions at all?
Thanks for we deal a lot with joint injury on the trauma side, and that sometimes when you have a dislocation, you're gonna have cartilage injury that you're not gonna be able to assess, right? So the cartilage looks okay, you look at it, and even if you don't put screws across the joint, 6 months later, a year later, you've got arthritis there, no matter what you do. How do you know when you're talking about sort of how do you attribute the fact that all our previous transarticular damage was screws and not just the injury itself? How would you differentiate those two?
It's a great question. The answer is I have no idea. The high energy ones, I don't think you can tell.
Yeah, high energy is most of them. Although sometimes the low energy ones are worse than you think, right?
Yes.
It looks like a low energy, but there's a lot more instability than you expect. Like you showed that on some of your slides.
I don't think you can truly differentiate. There is cartilage damage and high energy injury that you can't tell. You open up cartilage, looks great, but the cells are dead. But I think the low energy ones that got massive arthritis, it's like I just barely tripped and fell. Subtle instability with weight bearing, not the ones that were off. And they get massive arthritis. Those are the ones where I thought we were the problem. Do I have a perfect scientific way to tell you that? I don't at all. But it makes sense to me not to put screws across the joint. From my personal experience and talking to others that do a lot of these, the subtle ones should not do that bad. It just is offensive to me that we have a subtle injury and they do terrible. There's got to be something we can do differently. And if the one thing I can change is not put a screw across the joint, and that's an easy fix, then that seems to be an easy change we should make.
And I agree. I've gone away from putting screws. That was my training, put screws across the joints at Harborview. But I've gone away from that. But sometimes I was more thinking about what do you talk to your patients about in the future, right? So they're going to say, can I get back to whatever? I don't deal with the kind of athletes that Joe deals with. Most of the people I deal with are laborers or have other types of sort of more average jobs, but they have good questions, and I still don't have necessarily good answers. A lot of it's see in a year, which is.
We're not, that's why I fuse, most of them I'll fuse. And I think if you want reliability, they ask you that question, what am I gonna be able to do? 80% will get back to most of what they want to do if you fuse them. You do RIF, they don't do that great. The high energy ones.
The follow-on question to that is fusion in that environment is always a little tougher, right? So if you have someone comes in with midfoot arthritis and you're fusing them, you've got a stable alignment, you've got a stable joint, you've got stable soft tissues. High energy injury, a lot of those things aren't true. So do you do anything to increase your fusion rates, or have you dealt with problems with non-unions where in that environment? Because one of the things we think about sometimes is it's better to fix in that environment because it's a lower risk. If they go onto a non-union, you can always go ahead and fuse them. If they don't fuse, then you've lost bone stock already, you're dealing with a more complicated problem at that point.
For sure. So I think it's a great question. So if it's a high energy, but the bone stock is there, dislocations, those are easy to fuse. That's not what you're talking about. The ones that are difficult to deal with is where there's a lot of comminution. And in that case, I don't fuse right away. I agree with you. There's a lot of comminution, different bone pieces. I'll just fix them, get everything aligned, let all that bone heal and congeal, and tell them if it hurts in 6 months or a year, I'll go back and I'll fuse you, because it's very hard to fuse when there's literally just a jumble of bone, and creating a secondary injury to that joint, moving all that bone, there's nothing to put in there. So in those cases where there's heavy comminution of the base of the second and third, typically where it occurs, I will just transarticulate plate, get everything aligned, and then come back and fight another day. That's good.
It's just curious, obviously injuries are different in severity along the spectrum, but what do you tell a high level college athlete? What's their return to play timeline? 9 months, a year?
6 months.
6 months.
6 months. With the fusion, so CT base scan at 6 months, solid fusion, you can go back and play. If you can. So I tell them 4 out of 5 will go back and play, but you'll never be the same. I tell everybody that. No matter what I do, you're never gonna be the same after this injury than before this, so you might get back to play. And I say 6 months.
So it's, yeah, because if it's longer, then they miss that season and potentially the next season too, so they could get back the following season for the most part.
That kid played that year.
Right.
That's more just, he played 1 or 2 plays.
Yeah.
It wasn't like he played the whole game. But it takes about, if you look at all of the recoveries, 11 months to get back to play for an NFL athlete after LisFranc injury, but they start to play in 6 months to practice. A full return is about a year.
For the purely ligamentous injury, what are your thoughts on flexible fixation for the LisFranc versus screw?
Sure.
And do you add anything to it if you do it?
Sure. So I'm an authorized consultant for sure. So this gets back to arthritis, they'll get mad at me. I don't really think the internal brace is as great for the LisFranc fixation as we think. I've tried it because that's what I do. Having watched it, I don't think it's stable enough. So if you're gonna do it, you use the new version, go from the second to the medial cuneiform, then you have to go over to the inner cuneiform, to the middle cuneiform, because it doesn't have the strength of fixation to hold, because it's just an interference screw, it's the swivel lock, against pure translatory force. That's not how these are designed to do. So you put it across, you get a 90-degree or 140-degree curve that gives you better fixation. But in general, I don't do it. I don't think it's as strong as we need it to be. And if you look at all the data, fusions do so well. The concept is that the motion doesn't matter, stability does. The internal brace was designed for stability but preserving motion. The LisFranc articulation, C1, M2, or second TMT wants stability. So in that particular case, stability overrides any stirring of motion, so I'd always put screws. The only time I use internal brace is the first TMT because I think the motion is subtle, stress positive, only injury. X-rays are totally normal, but only because we lean into it on an X-ray or a weight break CT and then subtly pop it, maybe you can use these. Again, my heartfelt answer is I would open it and put a screw.
What's your construct for first? Internal brace for the first TMT.
Plantar medial, so I open up the same medial approach, and then it's the 3-5, I use the 3-9 swivel blocks now. So 3-9 swivel block, plantar medial, and then just distal to the anterior to 10-9. I pull it up just a little bit. Another 3-5, so 3-9 swivel block in the medial cuneiform, holding the foot in adduction and plantar flexion, and stick it in as tight as you can.
Do you feel like you have a good feel for that based on imaging, whether you're gonna have to fix curves, TMT versus
Yeah.
just stressing and drop?
I'd say 2 out of 3 I know beforehand, because I always stress info after a few seconds. But if they have pain in the medial column, I'll go. I'm not a person that thinks surgery itself is harmful. Once you make the decision to do surgery, I think you should be very cautious to operate. That's our job. Once you operate, never hesitate. That's my personal philosophy, right or wrong. If you're gonna do something, do everything. But don't make the decision to do something willy-nilly.
Great talk, Anish. Quick question. We all see patients with LisFranc injury, like we get the weight bearing X-ray, alignment is pretty good. We clinically suspect LisFranc injury, get an MRI, right? We see only the plantar ligament tear. Is there any role for conservative management, or how do you go about that?
You can, if I can visualize the portion of the LisFranc ligament and there's no diastasis any weight bearing X-ray, I'll tell them to use a boot for 6 weeks. I think it's pretty subtle. I'm not subtle, it's pretty rare for that to be the case, but it's a thing. So if they don't have real plantar ecchymosis, that's the patient that it's on. If you have plantar ecchymosis, all 3 ligaments are torn. It's the only way for blood to track all the way to the bottom. So if they don't have plantar ecchymosis, it's just an MRI finding of a subtle strain, portion ligament, but you can still see ligamentous fibers, I'll leave them alone. And not weight bearing for 6 weeks and weight bearing boot. And a few of those patients have done okay. But if your suspicion is even quasi, just do a percutaneous retrograde screw, in that case, the internal brace is probably the main and only indication I can think of for the IB would be that.
Second question is the intracuneiform instability. Like sometimes we do, when we do the fusion of the second column and the second TMT joint, and then we stress it, right? Do you stress it all the time and then see if the instability, intracuneiform instability?
I assume it exists every time. So if I do a second TMT plate, I put a LisFranc screw, and that effectively eliminates C1, C2 that are really crossed, or I'll always put a intercuneiform screw across. I basically assume that there is, when I realize even if you fix one, there's increased strain across C1, C2. So I always put a intercuneiform fixation in some way, shape, or form. And what I just say is connecting medial column to middle column has to be done every time you do a LisFranc injury. However you want to do it, you can't leave the medial column, middle column independent of each other.
So conventional wisdom was you don't fuse 4 or 5 because you need motion there. I noticed you have a lot of some of your X-rays and plates on 4. Were those temporary, or you're not worried so much about 4?
I take out 4 every time. So you could use K-bar, things like that. Those cases I couldn't get the 4th reduced. It's not that easy. I get people like, oh, I just put a K-wire across. I was like, that's not working. So I opened them up and the plate shoved the joint back in place and I took it out in 3 months. So yeah, I don't use K-5. I did it once on a lady. It took me 4 years to undo the damage that I did. She went back to CrossFit, but it was literally 4 years of like, this was a terrible idea.
One last question. Where do you stand on, there's definitely injuries that you showed where we'd be like, yeah, you should have an operation, but is there an age cutoff? And I mean age in a metaphorical sense, like activity level, someone in the household ambulator maybe goes out to the store, but is doing a lot of activity. They've got a 2 or 3 millimeter diastasis. Otherwise, you're doing okay. You have like a point where you're like, nah, I should move off, or
All these surgery, I think what happens is if you leave them alone, they have done. But I change what I do. So 75-year-old confident with a subtle restraint, if they will go to the OR, I'll do percutaneous fixation on them. Close it, solid screw, leave them alone. Not wait for this pop, which you may not listen to, but I minimize the soft tissue damage, the risk, but I want to provide that stability. Because then if 6 months later they have an abducted painful foot, there's only one way to fix that. And so you'd rather do a small operation, give them stability, instead of rolling the dice on that question. But I won't fillet them open into a big fusion. And MIS may change that in the future, but for now, that's what I do. I really don't think you can do a LisFranc. I don't call it a pet peeve. I don't think philosophically it makes sense. And if you do a lot of revision work, they're hard to deal with and they're angry. I got like, what, 20 minutes left, Joe?
No, 30, 40 minutes.
Okay.
Next talk. Yeah.
So this is the other talk Joe asked me to give, and it's striking the balance work and life as an orthopedic surgeon. So this is what it's like. You just can't do it. I don't think there's an answer here. And I'm not telling you I come here from a guy that has a perfect life, work-life balance. It changes every day. Once you think you've got it, it's like driving a car, which is my analogies for most in life. You're cruising along, you're set. Somebody cuts you off and drives you nuts. And it's never smooth. But there are things that I had learned over 18 years that I wish I knew a little bit of it before. So this is our goal, right? Work-life balance. Now we're talking about it. I think when Bobby, Venkat, Dave, Joe, Truitt, none of us were taught any of this stuff. It wasn't even mentioned. Mark Meyerson had work, and there was nobody on the right side. There was no letters. It was work, and then somehow work was on the other side too. And that was my idol. I wanted to be like Mark Meyerson because he was and is a phenomenal foot and ankle surgeon. But his life is a mess, and this is us, right? 8 hours sleep, do all this, and no matter what you do, everything just falls apart. Best of intentions, you'll never get it right. So I have no professional qualification. I'm not a sociologist or a psychiatrist. I got nothing. I fooled Dr. Parkman thinking I know what I'm doing here. So he really does think I have a balance, but I have not achieved any balance in the force. But he asked me to give this talk only if I already had this talk because he didn't want to give me any extra burden. I lied to him. I told him, sure. So my wife's birthday on Sunday, I spent 8 hours and I put this together. And my wife's like, you really don't understand the talk here at all. But, that's the life we have. But it was a very nice thing for me to reflect on my mistakes and good decisions. This is the most honest talk I've ever given. I've never given this talk before. So you'll get to know actually who I am, not my Instagram page. The one thing I will tell you, and I think this is something we should all try to achieve, is I really enjoy my profession. I am happy enough with my family. My family's happy enough with me. I don't think it's a perfect relationship. But I have no desire to retire. And that's something I will tell you should try to achieve in life. The job, you put so much effort of your life, almost half your life to get this far, or 30 left to get this far. Don't do this job like, I think I want to retire in a week, which is a lot of young surgeons like, I got burned out, I want to quit. And it's not because you're weak, which is what I told the residents and the fellows when they first started. So you are just weak human beings, put your head down and never complain. That's what we did, and that's better. It's probably wrong. And so you want to figure out how to make it work for you, because you're a very important part of society. There's not a lot of us out there, and you've invested too much to quit now, and the job doesn't have to be miserable. So when does the problem start? In residencies. For all of you young residents out there, and I'm old enough now that I no longer look like a resident. You've dedicated your life to the job. Your responsibilities really supersede all life priorities. You don't have control. Right? Joe says we're doing a case at 7 o'clock at night. Yeah, do a case at 7 o'clock at night, even if you had to go out for your birthday or you had some important event or anything, and it may not be important to us, but it's important to you. You have no control. So those 5 years are out the door. It's better now than it was for us. It's still not great. The fellowship, it's somehow you think fellowship is going to be awesome. It's worse because now you're stuck with these 3 faculty that Eddie's the only one, right? So it's 1 person of 3 attending. So Joe's like, I'm going to go on vacation. And Vegas said, well, I got cases, man. Like you're coming with me. So his life for the next year, this year, is all work all the time. And he knows this is his last chance to learn. So you now devote another year of your life to just trying to train. You don't control the schedule. You may have important things in your life that you need to do, but you can't do it. I mean, I told my fellow, you can take vacation as much as you want. You get 4 weeks. No one's taken vacation in the entire last 7 years of fellowship, but you can be the first. That's okay. And that's the problem. And so they're like, I'm going to be an attending, and that's it. Freedom. I'm going to control everything. It's actually not true, but that's what you think. I'm going to suck up these 6 years or 7. Some of you are now shockingly doing 2 fellowships. And then you're hoping when you're an attending, you've got all the control. Well, the truth is, and you know how his story ended, it doesn't end that well sometimes. And so this is what I thought. So this is my little life. So 2005, 2006, I got my new job at U of M. And this is how I kind of thought things through. The job itself required a fair amount of time. My family would get a portion of the time. Doing orthopedics alone is very stressful. You go from this coveted, kind world where you've got all these faculty helping you out. If something goes wrong, they'll help you fix it. You're not really responsible as a fellow or resident. You may think you're responsible, but I promise you, when we go to trial, I'm the one on the stand, not you. You're not named that often when things go bad. So you're not, the patients yell at who in the office when they have a wound complication or malunion or screw missed? They're yelling at the attending, they're not yelling at the resident. So yes, you're responsible, but in the end, you don't usually have the consequences. So doing it alone is a whole new level of stress that no one told me that would be there. Maybe I was stupid. And then loans. hopefully, if you all are lucky, you don't have any loans. I know when I look at the data, there's a huge burden on us to become a physician, which most people don't care about. And I thought, but I got this. None of that was true. Things changed very quickly. Within the first year, the job was a disaster. Academic work was terrible. Constantly writing things, politics at work. Luckily, you got Dr. Chabra as your chairman. It sounds like you have a very nice, cohesive environment here. U of M was a nightmare. Myerson told me that. He's like, you're going into the jungle. They're going to eat, right? Dave knows. Myerson told me they eat their young, literally, but when I took the job. I was like, well, Mark, I've signed the papers. Off I go, and they do try to eat their young. And so it was tough. Doing ortho alone and complications, I was the only foot ankle guy there. My partner, we'll get into that. But it's hard to do surgery by yourself. And when you're young, you feel like I can do anything. So Eddie, you're gonna see a bad total ankle case like you guys showed yesterday. I got this. I trained with Dr. Park and Truitt and Venkat. I got this. And it was 7 hours, 8 hours later, you're gonna cry, the leg was gonna fall off. You're responsible for that now. And I didn't realize that part. And loans were a disaster. And your family wants to have a home, you want to have a car, you want to go on vacation. I'm Indian, so there's a lot of family obligation. I had to buy my parents a car. I bought my father a car. I did a huge wedding. So we're just, you start here at zero, and I just went backwards, like just downhill. So 2006, I was more poor than I was in 2005. And like this, and so my sanity just got stuck in the corner. Then this happened. I'm like, come on, man, 2-week notice, he quit. And I was like, how do you remember, were you there, Dave? Yeah, and I love Bobby. Bobby is the greatest guy in the world. He had to do what he had to do, but he gave me 2 weeks notice, but this was also going on. My child was being born 2 weeks after the fact. We just bought a new home. Our compensation plan changed. It changed every year I was there, and I wanted to be famous. So I spent every weekend writing chapters in research. And so this is not working out that well. So 2008, 2010, I was traveling. As Joe looks at my CV, I was traveling all over the world. I was trying to keep my mentors happy. You are obligated to your mentors, but you are not their serf. You can say no, but I never did. Articles, reviews, lectures, I was constantly doing stuff. I was trying to have a second child, and anybody who's trying to have a child, that is probably the hardest, most painful thing to do. Shockingly. It should not be, but it's the worst if the baby doesn't show up. And we hired a new partner, and that costs money. There's only so many cases that exist. And I made that up the next year, but I look financially, it was $100,000 hit to get a new partner. And so I'm now still broke, more stressed out. My family life is going to hell. And 2010. So I thought, all right, things are going to get better. No, something happened in residency. Dave knows the story here. That did not work out well. I didn't trust our leadership. So I just wanted to leave. There was really no support for research. Resources weren't equitable. It was sourced that not every department works fairly. So it was an issue. I was exhausted with teaching requirements and time. You do get exhausted being academics. Teaching residents is difficult. It requires a lot of maturity to let somebody operate, to teach, waste your time at 5 p.m, to give them a lecture they may not care about, and to let them do cases where they're going to screw it up and you have to fix it. It's a lot of extra work. And I was getting 6 years into it. I'm like, I'm done. And at this point, you realize you're talking to your colleagues and everybody's like, man, I'm making $1.5 million. I'm owning a hospital and I'm not earning very much at U of M. And you're like, what am I doing? Right. So I'm not telling you that. I mean, I'm in academics now and I will tell you everyone should do academics, but that's my philosophy. And then my mother-in-law coded in my house when I was traveling. So I was in Germany, not Singapore. She died, almost died when I was in Singapore. So this was when I was in Germany. My mother-in-law was visiting and then she coded in my house. And we're not from Michigan, we're from Chicago. They were visiting. My wife called and said, you have to come home. So I flew home and she had heart failure and she almost died, but they saved her. And my wife's like, we have to go home now. So no matter what you do, there's always some new fun and exciting thing happening to your life. So 2011, this is a bad year now. I'm 5 years out into practice, so 5.5 years. And then let's look at the state of affairs. Well, I moved to Chicago at this point, and as I had to. I sold my home. It was not the market that you have now where you just bought a home 5 years and then you just made like $1 million. Things were not that great in the economy, so I lost $50,000 because that's my luck. I had a new job in private practice, and for those of you going to private practice, nobody's paying you money. Your partners are paying your salary. At UVA, at Northwestern, my partners don't care what I make. The hospital's paying for it. If you want $500,000 or $1 million to start your job, it doesn't affect Joe right now. But in private practice, whatever you want comes out of Dr. Chabra's pocket. And so he's not nice guy that he is, he's not giving you his money for nothing. So I took a 50% pay cut. My second child was on the way. I was broke. I had $10,000 to my name. I asked my father-in-law for a bunch of money to get a down payment on a house because that was right after the financial crisis, for those of you who are old enough to remember. So before the financial crisis, you could walk in with a promissory note and a penny in your pocket and lint. They'd be like, here, whatever home you want, you can have. It was really that crazy. You remember those days? You could just walk in 0% down, whatever you want. Well, then I moved to Chicago. That whole crisis happened. They're like, give us your firstborn and we might let you get a house. So I had no money.
You have to borrow from father-in-law,
You know it's bad, especially in our culture. You just don't. So I literally went on my hands and knees and told him, look, Sakina wants to move to Chicago. I have no money. Will you give me a lot? And he said, sure. So he gave me enough to put a down payment on the home and then refurbish it because we couldn't afford very much. And I had to pay him back, obviously. And then, so now I'm new job, no money. The practice was not what I expected. And I told Joe about this in the car. It was a slap in the face. It was absolutely nothing that I was told was reality. And maybe my expectations were wrong. You always blame yourself. So, but this is, you always look at those that have passed before us, and all these quotes that may seem corny, as you get older, they actually mean something. So success is not final. Failure is not fatal. And it's the courage to continue that counts. And I will give, this is obviously Winston Churchill, who got fired after this, right? He got the UK through World War II, and then they said, get the heck out. They hated him after that. So no matter what you do, no matter what your success is success for the day, and the next day is totally new. But no matter what happens, never give up. So you could quit, or you can rise up again. But I basically didn't do anything smart. So I changed jobs at this point. I went to Northwestern because at least it was in Chicago. My wife could take care of her mom. And politically, it was a nightmare. I was fired from every single AFIS course ever. So all those lectures, and if you look at my CV carefully, which you should never do because it wasted your time, all my AOFAS talks disappeared in 2012 to 2020. They're just gone. All my efforts was wasted. I thought I just basically threw all of my life into the toilet because all that academic stuff I was doing was suddenly stripped away from me. And I was like, I really screwed up my life here. I had to stay in Chicago for my family. My mother-in-law had a heart failure. My wife took care of her. And I was not really a great husband. I sacrificed all of my family for this academic career, and it was stripped away. But I did miss academic medicine. Not the publishing as much, but I missed the residence. I missed the collegiality. What you are doing right now does not happen in private practice, ever. The only time you'll be doing this, talk about money and who's not making enough money and who's not busy enough, who's not bringing cases to the surgery center. And I'm not saying private practice is bad, but just understand that it's a different, if you just like hanging out and chit-chatting, what you did last night at Dr. Park's house, no private practice ever does that. It's a waste of time. There was no money being made. We wasted time. No one does that, but it's a different world in academic medicine. And I miss that. That's what I was born to do, I think. So if you look at every slide, what's missing? You've not seen my family at all. And I will tell you, do not let this be you. Your family should be 1, 2, 3, 4, and 5. Not in my book, it was not on the list. And so I truly was not paying attention to that which mattered most. That's my lovely wife. And this was at that year. I pulled it from their year. That's my little baby Rohel, and that's my beautiful son Kamran, who's 16 now. So what I was feeling, this is honestly, I was feeling a total failure. I had burnout, which I will tell you, this word did not come up back in the day. We did not talk about burnout. This burnout is weakness. That's what I was trained. I only have this word now as a 2023, but when I was feeling this, I just felt like a big loser. I didn't talk to anybody about it. I just, I was embarrassed for myself. I hated going to work. I had to drive 25 miles each day, an hour and 10 minutes to get to work. And I will tell you, every mile I hated my wife and myself even more. I blame my wife for this because she made me come here. And that was wrong. It's not true. And I was financially, one more time, I was $0 in the bank. I called my father this time because tail coverage is something I didn't understand. Why would I? I'm a stupid idiot. I left private practice. 9 months later, I called the ISME, which is Illinois State Medical Society, and I was like, what's my tail? She told me $60,000. I threw up. I was like, what do you mean? I did 40 cases this year. I've been there for 9 months and I just do foot and ankle. She's like, no, it doesn't matter. It's like, that's a discount. I'm like, what's full price? Well, after 3 years, you have to pay $180,000. We need the money in 30 days cash. If you don't pay, you're not covered. Well, Illinois is one of the most litigious states. Cook County is the most litigious county in the country. I think Philly has one that's worse. So I had to call my father. I was like, Dad, I'm broke. I need $60,000 right now. I explained it to him. So now I'm in debt to my father-in-law and my father. It's getting better. What are you going to do? I only made $130,000 because I didn't work the whole year. My partners were livid at me. I did every case, every extra thing I could do for my partners to pay them back, but they weren't happy with me. Nobody wants them to leave in 9 months. I was a terrible father and a terrible husband at this point, and I brought my disappointment home because I didn't know how else to deal with this. And so it's not really a great feeling. So now you're looking for that epiphany. At some point, this dummy's going to figure out life. It just gets worse. So I went to Northwestern, and I thought there would be solace and comfort in becoming famous all over again and getting that my job was my solace. So I put all my effort into my job. I took every case. I never said no. I worked late nights all the time, no regular schedule. My son never saw me. Started a fellowship because spite. Had started a fellowship. He was one of the people that I left. So there's a lot of political nonsense, but I have a lot of pride. So I found out he had a fellowship, and he told me he was going to do one with me. So I told Peabody, I sat him down. I said, look, I want a fellowship. And he's like, why? I told him spite. And he's like, okay, sure. You know, that's why I like Peabody. He gets me. Now the fellowship it's not just for spite, but it was, I wanted a fellowship. So more pressure on the family because fellowships are more work, right? Eddie, your work, you're not actually that much work taking away from us. You make us do more work, but it's joy. It's not just work, it's joyful work. Now we're getting home at 7, 8 p.m. routinely, which is hard on the family. Still haven't learned anything. I did more research, more international academics, because the national academics were taken away from me. So I just put all my efforts into international travel, but not home. And then Meyerson wanted me to write a book. I was in Saudi Arabia giving lectures with my old fellow, and he's like, hey, I want you to write my new book with me. What do you say to that? Of course you say yes when you get a chance to write a book. So there was another 1.5 years a week. And if you've ever written a book, it's a stupid idea. It's terrible. And your wife will leave you. Everybody I know, or husband will leave you, or spouse, whatever, that's written a book. The other person said, don't ever write one again. That's what I was told after this. So now I'm losing control, and I love video games. So that's why I put that in there. So 2016 is where finally God came down and said, we're done with you. I broke my arm taking my son to work, both forearm fracture. The first thought that came in my mind was what? I have cases on Monday. What am I going to do? What is wrong with you? But that was my first thought. And I didn't want my son to hear me scream. And my third child was on the way. My wife is 1.5 months from delivering. And at this point, I was taking my wife for granted because she's going to deliver, and it was all about me. My arm hurt, obviously. So once I had it fixed, and about a couple weeks into recovery, we were in the car at a jumping house. You waste your time at these disease-infected places for your kids. And she basically said, I was thinking about leaving you. I was going to take all the money out of the bank and leave you. I started laughing. I was like, what money? We're broke. We have $50,000. You can take all of it, honey. You're not going to live for more than a week. Take it. I got nothing. I am a man with nothing. And a friend of ours who came, and she was at Michigan. So we've been friends with her since college. She came and told us, she's like, I'm sorry, you're his dad. And I realized I was just an angry individual yelling at my children all the time. And it was now 10 years after leaving practice, and I'm still broke, and I'm a bad human being. And this time you have two choices. And finally, I changed. You can blame the world. You can blame everything around you for your problems. And that's okay. Sometimes the world is the problem. Or you can just kind of look inside and say, well, look, this is the world I'm given. This is what's happening to me. It's probably my fault. And I was letting everything around me control me. My patients, my job, trying to make money, academic work, and my own ego was the biggest problem. And at some point, you have to take a step back and say, stop. So when you have imbalance in your life, this is what happens. It happened to me. You're unhappy personally, and you may not even recognize it. Then you put that on your family. Your health suffers. I had chronic GERD. I was popping 4 or 5 Pepcid ACs a day. You're supposed to take one. That's what the box says. I just popped them like candy. I could not stop having pain. I was fat. I was 198 pounds. I could not control it. I was getting fatter. My asthma was terrible. Every day I woke up, I had a headache. Every day. I thought it was because I worked so hard. I haven't had a headache in 5 years. Every day I'd have a headache. Patients were suffering because you're not making good decisions. You're making decisions out of arrogance or anger, whatever. Your staff suffer. You're not a good person to be around, right? Nobody wants to be around you when you're chronically unhappy. You may not realize that, but People around you suffer for your unhappiness. So for this lecture, and I didn't look at this in 2016. So you look at, this is an 85-year-old study, not an 85-year-old person. It's an 85-year-old study. They do this study about life. And one of the things they looked at was what makes you happy in life, what makes you live longer. It's published in 2023, and it's a continuing study. So it's not what you think. Maybe you already figured this all out. It's not your career achievements. It's not money. I promise you, it is not money. Shockingly not exercise or a healthy diet. That doesn't make you live longer. If you look at the data, or happier. It's this. It's positive relationships that keep you happier, healthier, and help you live longer. And that's the hands down the thing. It's the people around you that matter the most. It's none of the stuff that you compare yourself to. When you go to any meeting, any dinner party, family party, right? Every family party, everybody's whipping out what car they have, where they went on vacation, Instagram, Facebook, all that garbage you see has nothing to do with making you happy. That's just people who don't have in there, and they may or may not be happy themselves, but they want to show this thing of happiness. And you're trying to keep up with them. And in the end, you're just killing yourself. Be kind, love those around you, and spend a lot of your time cultivating that, and your life will be better. You know, Joe has 2 beautiful dogs. We just got a dog. And this is really what you want. I'm not saying get a dog, but dogs are great. Is that you want to, just like that, look how much love they have for each other in that picture. That's what you want. You want to be able to go home and you want to look at your spouse or dog or friend, whatever, and just be happy you're around them. That's honestly all that really matters. So finally, if you like, I like analogies. So the Phoenix rising, you finally are able to reinvent yourself. I opened up to my 2 best friends. We both were buddies in fellowship. All 3 of us were going to be the most famous medical surgeons in the world. We're all really smart, top of our classes. And nobody for 10 years said one thing. And then one day I caught, said, look, man, my life sucks. The other guy's like, my life sucks. He had depression. His wife was going to leave him. The other guy said the same thing. He's like, I'm leaving academics, man. I can't do this. My wife's going to leave me. I hate it. We don't talk to each other. Talk to your colleagues. What you're going through, everybody's going through. Joe didn't tell me about his experiences either. We all have bad experiences, have to. We should be understanding that your troubles do not make you weak, do not make you a bad surgeon, do not make you a bad person. You don't have to walk this earth alone. Just talk to your colleagues. We're all going through the same thing. I finally communicated to my wife. I didn't talk to my wife. I was talking to my wife for 10 years, telling her what I was going through and telling her what was going to happen. I finally just opened up and communicated with her, like, what do you want in life? What am I doing wrong? And that finally allowed me to change. And then I realized I reprioritized everything. Family first, academics, more than academics, clinical productivity, and money. I'm not telling you, I work my tail off. Joe knows I'm always working, but that does no longer controls what I do. And then no one really cares about you except your family and friends. In the end, that's really all that. No, your patients don't care. I will tell you, your chair, as much as Dr. Chhabra is a great person, he cares about you, but in the end, not as much as your family and your friends do. Your colleagues do, but not as much as you think. And I'll tell you, the administration doesn't care about you. I promise you that. You behold your life to these people, they leave, and they could care less. You're just you're a widget maker. Don't forget that. So it doesn't mean you disrespect people, treat everybody with respect, but just know that if you're going to sacrifice, who should sacrifice in your life? It shouldn't be your administration should be sacrificed versus your family and friends. And that's not what I was doing. So this is now real lessons like time management. So you have to prioritize your tasks and setting up realistic goals. When you look at your workday, you have to count not just how many patients you're going to see when you're young. I would see 55 patients a day because of pride. I see so many patients. Well, the truth is that math didn't work out. I had to do clinic notations, patient callbacks, MRI reviews, epic messages. So I may be done at 5 o'clock with clinic, but I'd be getting home at 8:39 because that work had to be done. There was no way to not do it. Don't book patients that late. If you can get till 5 o'clock, that's fine. And but make sure you calculate when you're young, all that extra time that you may not be doing, right? Residents and fellows don't do epic messages. Mine don't. No callbacks. They don't deal with the staff. They're like, they're done. Clinic's over. Woohoo, I got my dictations and I'm going home. And my fellow will see not as many as he should because you're learning. But you're not learning anymore as intending. The job has to be done. You got 50, you bang it out. And if you have 40 of the 50 dictations to do, that's your problem. What can be done? So there's always a lesson. Well, spend money to gain time. That's the way to think about this. So scribes, AI-assisted notes, look into technology to help you. Earn less to gain time. See less patients. That clinic at 3. More space between patients dictate. You don't always have to just see the most and make the most money. Gaining time is the most important thing. When you look at all these extremely rich people, of which I'm not, as I've told you, time you'll never get back. Delegate, make your PAs answer messages. Tell them, not make, but talk to them. Create protocols for them so they can answer questions for you so you're not having to do everything. You have to trust your PAs, you have to educate them. Have your athletic trainers, MAs, do the dressings, orders, empower and educate. Treat your staff as equals, not as minions, and they'll do a lot for you, I promise you. What I have done, I do clinic, I crush it from 7 to 1:30. We don't take a lunch break. I check with my staff. I ask them, what do you want to do? Do you want to just be done early so you can eat at 1:30, or do you want a long lunch break and get done at 3? They said, let's just fly. So if we see 40 patients in a short time, my PAs answer all my messages. Patients ask me, this is the best part, how do I get a hold of you? My answer is you can't, flat out. I don't care how rich you are, you cannot call me. My team is available. Do not give out your cell phone. I will tell you this 100,000 times, even in private practice. Patients do not need your cell phone. They will take your soul if they could. Don't give it to them. I'm busy as hell. You don't have to be super available. Your family needs you. When you get home, that phone turns off. MA in clinic, treat your MAs with respect. I see a lot of surgeons treat our staff with disrespect, as if they're just there to do things for you. Treat them with respect. Ask them questions. Is it okay if I add this patient on? Yes, you are the surgeon. In the end, it's always your decision. There's no question about it. But treat them with respect. Have somebody do your DMEs. Talk to your PAs, empower them, have them run their own clinic. See your 2-week post-ops if you can, but then still see your own patients after that. Everybody develop your own protocol. Do your dictations as best you can. Don't do them at home anymore. Whatever you do, don't bring your dictations home. Try not to. Crank them out in the clinic, do it, get there early, do a clinic, but don't bring that at home. I stopped doing that, and it's probably one of the most important things my family has done. So this is destiny. I don't know anybody who plays video games, but this is destiny. So my new license plate is going to have legend, because the whole thing is called Become Legend, but you have to have a hobby in life. So mental day. I take a day off a week, and I went to Peabody one day. I said, Dr. Peabody, I don't want to work Wednesdays anymore. He was like, okay, you're going to make less money. I said, I understand. He's like, good. You don't need to make more money. And a lot of this comes from my chairman. He's a good mentor. So you lose money. I make money only when I work, but it allows me to do normal things. I go to the dentist. I actually see my wife. We eat lunch together. I can pick up my children. And yes, I do go to the car dealer a lot now. I drive on the weekend, so I have hobbies. I drive in the morning, so it doesn't bother my wife too much. I have some friends outside of work, get non-physician friends. You cannot hang out with only doctors. We are not normal human beings. We're not. We all complain about the same things, and you start thinking that what you have, your complaints, is what is a real thing. Talk to people that have regular jobs. You realize you are blessed. So I talk to the car dealer buddies of mine all the time. I just chit chat and talk to the sales guys and managers and hang out for an hour, have coffee. We're lucky. And then do something. I play video games. If I'm stressed out, I just hang out for an hour and just shoot people on the video game all day, and it's a blast. Do philanthropy and mission work. The last one is probably something that I did in the last 2 years. I've done 3 missions. I'm part of the Steps to Walk. It is the best thing you can do. It makes you feel like nothing else in this world can. And so if you have the opportunity, go out there and give it a week. I mean, I do a week. I wanted 2 weeks a year. Hopefully this patient will give me my professorship, named professorship. I can take off more. It is the best thing. I could stand here for 6 hours and tell you how awesome it is. You make nothing, you get nothing, but your soul is just, you really come back fired up to fire off another year of work. Because there's only so much second toe pain you can listen to. And you see these people who can't walk, they're totally deformed, they're so grateful to even have a leg. Physical health, this is important. Nutrition, it's your own journey, do what you want, but I really cut out a lot of sugar, intermittent fasting, low carb. I'm not by any stretch of imagination a nutritionist, but you just can't eat garbage all the time. It's not an excuse that we're busy to eat garbage. Garbage in, garbage out, it destroys you. So try to eat as healthy as you can. Whatever works for you is great. Do some exercise, home weights and pull-up bars. That's all I do. I don't go to the gym. I tried. I didn't have the time. It was too much away from my wife. I do push-ups in the morning. People make fun of me all the time. My colleagues say, what are you doing? Are you doing yoga? I have a yoga mat, and I do push-ups and sit-ups, and I do squats and core exercise in the morning before the clinic starts. I don't care if you think it's funny. I do it in my suit. Don't worry about it. I got to do something, because by the end of the day, I'm exhausted, and I'm in my car at 5 o'clock in the morning. I just do it at work, but do something. Establish boundaries, and this is between you and your chairman and your boss. It's a job. You need to assert control of your schedule. Don't let patients dictate your life, not money, not partners, not academics. You have to say no to patients sometimes, not all the time. But I'm sorry, I don't have time. I'm going to send you to a partner. You don't get along with the patient. You don't have to treat every single person that walks in your door. There is no obligation in this world. When you're young, you think, if I don't treat this, nobody else is as good as me, or I have to. You don't. You just don't. And that one patient will ruin your 6 months of your life. We all have them. Don't. You can say no. Keep that in mind. Say no to other doctors. Oh, Anish, I got this person. Can you see them? I'm like, I go on vacation soon, but okay, I'll get them in. I'll add it on. The answer is no. You know what? I'm sorry, I'm busy. So have one of the other guys see it. It's just not, I'm not available right now. It's okay. You're not obligated to your colleagues. Your family needs you too. I said no to the hospital. They would add on all the plus cases at 10 o'clock at night, 9 o'clock at night. Oh, Anish, we have to do all the elective cases. After years, I was like, you know what? I'm done here. I called my chairman, like, Peabody, I'm not doing these anymore if they're going after 5 o'clock, because I did all the plus. Like, this is not fair. And then they said, well, it's a nursing issue. So I called the VP of nursing. I was like, hey, this is ridiculous. I'm not doing these cases at 7 o'clock, 8 o'clock at night. My family's suffering. I'm not doing them anymore. And I operate on both of her ankles. And so she walks because of me. So she likes me. And I was like, I need to do this at 5 or 4 when I'm done. She's like, okay, no problem. Suddenly, all the nurses showed up and the ORs opened up for me. You can complain and get what you need. You're not asking for anything wrong. You're trying to take care of patients and you're trying to not be home at 10 o'clock at night. There's nothing wrong with that. Demand what you need. Who you shouldn't say no to. You your family and your friends. You owe them yourself and your time. They're understanding, but don't let the job take advantage of that. They cannot always be secondary or tertiary to your job, but sometimes they have to. This is not a the heck with the job. We are orthopedic surgeons and doctors first. They need to watch out, return to OR, your physician first. You always do the right thing, no matter how uncomfortable life may be. And so there's an emergency, you have to take care of it. But what I'm trying to get at, these elective cases that you keep adding on, those don't have to go. So you don't have to say no to everything. Technology, get Epic off your phone. Who has Epic on their phone right now? Dr. Chhabra probably does, right? I'm sure you do.
One of the residents showed me how to do it.
See, I put it on and I took it off. Why do you need Epic on your phone? Who's dying? You're orthopedic surgeons. We barely, during COVID, we were useless. I'm not joking. COVID changed my mind completely. You are not an essential worker. You are not essential, right? By definition, we were not important. So get rid of Epic. That's my advice to you. You don't need it. Turn off notifications. My phone doesn't ding at all, except for text messages because it starts later. And tell your staff to call you if there's a problem, you're on vacation at a meeting. You don't have to constantly check your Epic. Tell them when there's a patient problem, just call me or text me. That way your mind is constantly, let me just check, right? You can't function like that for 50 years. If you're feeling overwhelmed, tell your administrators. They actually are legally obligated to help you. Nobody knows this, nobody cares, but they are obligated to make this a well place to work. Whatever that means, I've never accessed that, but you have these abilities. Patient reviews. I refuse to look at these now. All this is stress, right? You see 80 people, 100 people a week, 400 a month, right? Thousands a year. You don't think people are going to complain? It's by definition, unless you're God himself or herself, you're going to get complaints. Unless you're getting a deluge of disaster complaints, you're not pleasing everybody. I told my administrator and the vice president, like, I never want to see these again. I'm like, I'd be like, well, everybody likes you. I'm like, I don't care. You're supposed to like me. That's my job. That doesn't make me feel good. There's always some numbnut giving me some grief about whether I wore a suit that day or not, or whatever. The complaints are insane. And I was like, I don't want to see these ever again. So I stopped getting them. Like, if I'm committing some sort of HR violation, I'm really being bad, doctor, come and talk to me and I'll go over everything with you and I'll change. But I don't want to hear every nonsense. It's just headache. The hospital's giving you stress because they want these reviews for their hospital. You have them here too. You're all reviewed. You're all Google reviewed. Don't ever do this again. I told them, don't ever show it to me again. I'm done. I don't care what anybody says about me. I'm a good guy. I'm a good doctor. They're like, yeah, you are. I'm like, so why are you telling me this stuff? I got to see the bad ones so I get angry for that week. I'm not dealing with it. I know everybody doesn't like me. That's like life, dude. Patient access issues. It's a system problem. It's not your problem. Now, Dr. Chhabra may not like what I have to say here, but the hospital would come to me when I was by myself, say, Anish, we have a 6-week access. You need to open up more clinic. You need to see more patients. And I would start seeing 60 a day. That's not your problem. Now I tell them that's a you problem, not a me problem. This is my schedule. If you can't get patients in for 2 months, that seems to be that you need to hire more people. Don't talk to me ever again. And I am old enough to do that and respected enough that I can do that, but it is really not a you problem. If they have their own metrics, they don't care how much you work, they work till you die. Administrators don't run your show. Do your job, don't be lazy, but you can't crush yourself to get some metric that matters to them, not to you. I demanded help. I wanted more help, they gave it to me. All the stuff I told you. I'm a good citizen. I really am. Peabody likes me, I do the work, but I am no pushover. Talk to others. This is how you overcome challenges. Everyone's in trouble. Surround yourself with good, kind people. These are my partners in India, so we're all brown. It's not that I'm racist, okay? But we happen to be in India, so everybody happens to be brown in India. This is one of the mission works that we did out there. But that's my partner on the left, and we truly are happy. I mean, I hired him, he was my fellow, and I made him come to India for the mission trip. And that's my brother in the back. Surround you with people that want to do good things and help the world a little bit. It will make your life a million times better. If all they talk about is money, vacation, their house, their car, how I'm better than somebody else, stop talking to that person. Get rid of cancer in your life. It's bad for you. I don't know if you listen to Oprah, but you cannot surround yourself with terrible people. They will drag you down. These are colleagues of mine. We're all buddies in Switzerland. This is the course that I went to a few weeks ago. All good people that love academics, love teaching. You surround yourself with these people, you'll be a better person. Stop comparing yourself to others. It is a natural phenomenon. Instagram, Facebook, TikTok phenomenon, it's worse now than ever. Everyone's showing about their best lives, but it makes you feel bad about yourself. And just don't. My mother-in-law, and she passed finally, so she told me to look up, to look down and not up. I didn't understand what she meant. What she's saying is that, remember, you have a great life. I want all of you in the audience to know these numbers. We're very lucky to be orthopedic surgeons. And I will tell you, this talk is only because I'm middle-aged. And I was telling Joe, or I was telling Venka, that wisdom is not because we're smart. Wisdom is because we've experienced a lot of life and we've seen a lot of death. And I have seen both. And you just learn that all the garbage that we think is important is really not. Some may work more and some may work less. When you look at some of us out there, make more and make less, right? I don't make as much as people think. I exude a good life. But it doesn't matter. If somebody's making $1.5 million and you're making $500,000, $400,000, you're doing well. You're doing great. You just remember, I looked this data up for you yesterday night. 99.9% of the world works more. You think you all work hard. Go out to the real world. Every orthopedic surgeon outside of America works 50% more than you. They all have 6-day work weeks, besides like Switzerland. All of South America, 6 days, India, 6.5 days, all Africa, they're all working like machines and they're making nothing. So we complain, and we should, because we have the ability to, I guess. But just remember, everybody else is working way harder than you and they're making nothing. 99.9% make less than $400,000 a year. All of you in the audience, orthopedic surgeons, if you have a reasonable job, you'll usually make around 400 working hard. 99% of Americans make less than you. You're doing great. So whether you want to make 400 or 1 million, remember, you're still at the top of the mountain. Look down. Don't look up at the 5 people on top of you who are hitting the peak. There are a lot of people that have nothing. There's a nice TED Talk. You should look at this TED Talk about what people have and what wealth is. My wife made me listen to it, but you think like a toothbrush is assumed that you'd have a toothbrush. I have 25 toothbrushes sitting around. I think the number is like 70-80% of people have one toothbrush for the family in the world. You're too young if you're a resident to listen to this stuff. But as you get older, just remember, when you get angry, just root yourself a little bit. So take time off. Until like 3 years ago, I never took more than a week off in my whole life, not once. I don't care at all anymore. I am gone all the time, and I don't care. Now, Bobby, Dr. Chopper may not appreciate that, but when my wife says we're going, I'm like, we're going. We're going to Christmas. I took 2 weeks off. I took a week off here, a week off there. It doesn't matter. When I work hard. But if my family says we need to take 10 days off for vacation because that's what we're going to do, I'm gone. Don't book me anything. I'm out of here. And you can take more than a week off. You can't take more than a week off every week because that's not math. But you can take a vacation. And if your family wants to go somewhere for 12 days, go. No, remember, during COVID, I'm telling you this from my heart. Look at the bottom line. Not one person complained about delaying getting into my clinic. Nobody complained about their plantar fasciitis. No one demanded. You couldn't see me for 3 months. I don't know what you all did here. 3 months, no elective patients, no elective surgery. I was the only one that worked. I sent my junior partner home. I sent my senior partner home because I told him, I said, if somebody dies from COVID, because we were all scared, I'll die first because I'm middle-aged and I have good insurance and I've lived a good life, so I'm ready to go. It's fine. You're too old. My old one say, you're too old, you're gonna die first. And the young one, I'm like, you're 3 years out, you can't leave yet. So I stayed and nobody cared. And I sat there in my office by myself doing nothing all day. And I realized nobody cared if I was alive or dead, or nobody needed my services. So you can take time off, right? Patient's not gonna die if you're gone for 12 days. Anybody can do the emergency cases. Take care of yourself and your family. Never miss a wedding. Never miss a funeral. I'm old now. Never miss a funeral. Somebody's gone, family member. In Islam, I'm Muslim. You have to go to the funeral in 24 hours. Now, what do? Oh, I can't come. I have surgery the next day. I have clinic the next day. I can't come. I'm not going to be there tomorrow. Someone died. I'm leaving. What are your patients going to do? They'll figure it out. The funeral will only happen once. Weddings will only happen once. I missed some weddings and funerals, and you'll never forgive yourself. Just go. Your job will be fine. Patients will be fine. Don't cancel your patients, go to a concert the next day or something stupid. That's different. But if it's a life-altering event, you go. That's what makes your life a true life. So it's always in flux. Dedicated 1 day off a week if you can as you get older. When you're young, you can't do this. There's no way. Or at least a half day. Get your clinic as efficient as you can. Limit the things that you can, and some things you just can't fix, obviously. I've learned to say no, but never to my family. If I can make it happen, I do it. My wife asked me, my kids asked me, can you? I said, let me see what I can do. It used to be, no, I'm busy. You know I'm busy. That's the wrong answer to give. The answer is yes, let me see what I can do. Academic timelines are not set in stone. I still do a lot of academic stuff, but none of these dates are in stone. I used to think they were. They're all relative. Remember, this is free work. What's the worst they're gonna do if you don't write a chapter for somebody? Not ask you to write a free chapter again? Great. I'm serious. Don't miss any obligation or family event because Monday you have a chapter due and it's Sunday, there's something to go to. Let me tell you, I'm 6 months behind on every single deadline. The deadline is when, you know what the deadline is? When I get it done. Because nobody else is doing this. Why do you think I keep getting asked? Nobody's doing this free work. So not saying you should be delinquent, but don't skip things because you have some random deadline. Do it when you have free time, but never sacrifice. I sacrificed so many things for chapters and then they wouldn't get back to you for 3 months. You'd be so angry. You get it done. So this is the car thing that we're talking about. One thing I'll tell you, you're never going to be famous or important. You may think you're famous. You may say, wow, Dr. Chabra is the most famous hand surgeon and chairman. If I put Dr. Chabra on a plane, nobody would know. He's another bald Indian guy sitting on a plane. All right? I think I'm super famous foot and ankle. Everybody knows Anish Kadakia. People in foot and ankle don't even know who I am. And nobody cares who you are. Angelina is important. Brad Pitt is important. They know. Everybody knows who they are. You are nothing. What does that mean? That means all this extra paper, this extra talk, treating that important athlete that you think is so great, that billionaire, sacrificing everything to make that, nobody cares. Just keep that in mind. You do your job. Everybody should be treated the same. If you really care about that paper, do it. Do it. I do a lot of academics, but it doesn't really matter. You're never famous. If you get that out of your head, you'll stop making dumb decisions. Don't let a false sense of pride lead you on a path where you look back and you see your family, your health, happiness in the back mirror. I have a lot of older colleagues and their lives are nightmares. So don't let that be you. Find a passion. The job is my first passion. Besides my family, my job is my passion. I live, eat, and breathe foot and ankle orthopedics. It's literally what I do. However, you need more than that because this job cannot last forever. So I love cars, I love video games, I love my family, and don't let money drive your life. And that's really the long and short of it. True value is personal cost per dollar. That's what I would tell you when you measure making money. Measure that in many ways. Time, family sacrifice, joy, friends, physical health. It's not, if I work an extra clinic, I can make an extra $50,000. Ask yourself the personal cost to make that extra dollar. Is it worth it? Making 20% more may cost you 30% more of time and effort and family cost. If that's worth it to you, great. But it's not just a matter of hours. It's not that simple. So we lost my mother-in-law 6 years at the end of the talk. 6 years ago, one day before my fourth child was born, I drove from the hospital to go to the funeral. This is where all my life changed. You realize none of this is, nothing God gives you is set in stone. My wife had to stop working to take care of the kids. She's a non-op sports medicine physician. It is not easy. If any of you decided right now to stop working, you think staying at home is a good thing to do. It is probably the worst thing to do with 4 children. It's horrible. You lose a sense of yourself, a sense of purpose. The other spouse who's making all the money has an increasing sense of self-importance. It was during COVID, so she was at home. I was at work talking to people. You have to support them more than you realize. All this political aspiration is gone. I'll never be AOFAS president. And I'm not saying it's a bad thing, but you have to make a personal choice. You can't do everything. Is it important to you? For me, the cost is too high. My personal cost is too high for me, and I quit. I still participate, as Joe knows, but I don't take the extra time to do that because it's not for me. And I've lost friends and family who are exactly as old as I am. And once that starts happening, you realize there is no tomorrow. Today is a gift. And I don't want to be too philosophical because I'm not, but today truly is a gift. Tomorrow is not guaranteed. Enjoy the day, enjoy your family. You can't just keep waiting for the next day. Thank you very much. And this is what matters. Those are my boys. We all gave up on being powerfully political. We see each other more. And this is a few things. This is the way the world ends. This is T.S. Eliot. It's not with the bang, but with the whimper. And what that means is when you die as an orthopedic surgeon, nobody cares. There's no parade for you. You get in foot and ankle, you get a paragraph in stride, which not one of us reads. Okay, I'm not joking. And at Northwestern, you get an email and you're forgotten. Only your family and your friends will remember you the next year. So remember, you can put all this stuff in and all this stuff, but at the end, you get a paragraph and an email. Don't let that be your legacy. And I tell my wife this all the time. This is my philosophy in life. And this is why I have enough in my retirement, but I live life fullest of the day. It's the journey, not the destination. I'm not working for retirement. I'm working to enjoy every day of my life. And so you have your own philosophy in life. And that's what matters the most. That's us in London. That's my family. You know, you figure out what's good for you. It's the job for sure, but don't let it only be the job. It's just, and Jim Holmes, who, you know, he used to tell me all the time, it's not about you. And that's the best advice I can have when you lead your life. It's not about you. This life is not about you. If you keep that in mind, it's about everybody around you. You'll really have a really wonderful life. That's it. Thank you so much.